Well, good evening, everybody. It's a great pleasure to be here, with you, at least virtually, at the Saudi Hematology Conference. And I'm going to whiz you through 20 minutes of the novelties in relapsed refractory CLL. My disclaimers, I won't read through them apart from the very first one. I'm going to very briefly touch on a couple of medications that are not approved by the Saudi FDA, so please refer to the checklist of the FDA for approved medications. And these are my disclosures. So, as you probably all know, retreatment with chemoimmunotherapy in CLL confers a very poor progression-free survival, and we've known this for quite some time. And I thought it'd be interesting to list the different studies that have demonstrated the futility of chemoimmunotherapy in the relapsed refractory setting. And I've just highlighted for you the progression-free survival in light blue. And you can see that it's the PFS, irrespective of the regimen with chemoimmunotherapy, is in the order of a year, maybe a couple of years, and maybe a little bit longer if you're pushing it with FCR. But of course, the FCR therapy is only tolerable to a minority of patients with CLL. Clearly, there's not really a role for chemoimmunotherapy in the relapsed setting in CLL anymore with the new agents. So the ESMO 2021 guidelines really set the scene for the management of relapsed refractory CLL. And as you can see, obviously, patients have to have symptomatic disease. That has not changed and is still in a very much a paradigm in the IWCLL guidelines. And then the patients are being subclassified in 3 different groups: the ones with high-risk CLL and 17p disruption, the people with a short remission duration, and that's defined as less than 36 months, which has kind of changed the definition from previous chemoimmunotherapy times. And then the patients with long remission duration. And you see that really there is no role for chemoimmunotherapy in any of them. So I just wanted to briefly run you through the main and rationale of why these guidelines were written in the way they were written. So first of all, you're very aware of the RESONATE study. It was the first study published of ibrutinib. It was a study in relapsed patients. At the time, these were really poor risk patients, and patients were randomized between ibrutinib and ofatumumab, which was felt to be the best standard of care treatment available at the time. Importantly, I've highlighted this here for you. The patients had were really a high risk, enriched. Over 30% of patients had 17p deletions, and a large proportion of patients, over half of them, had equal or over 3 prior therapies. So this was a very poor risk group of patients. Many patients had gone through multiple rounds of chemoimmunotherapy. You might remember, the times 2013, how it was. The final analysis published a couple of years ago now showed that the median progression-free survival of ibrutinib in the relapsed refractory setting was about 44 months, and at 60 months, still about 40% remained in remission. There was no difference in overall survival, but that is because you might remember in the RESONATE study, the crossover was allowed. So patients relapsing on ofatumumab were then subsequently treated with ibrutinib. So no surprises here, really. And then the second study that's really had a big influence on the way we are managing relapsed refractory CLL was, of course, the MURANO study. And this study randomized patients between venetoclax and rituximab of 2-year fixed duration, so 24 months of that treatment, against bendamustine and rituximab. As you can see, really at that point in time, the patient population had already changed, and the inclusion criteria. The MURANO study essentially said that you had to have 1 to 3 prior lines of therapy. And because of the randomization against bendamustine, many patients with TP53 disruption were actually not entered into the study. So the number of patients with TP53 disruption was relatively less than in the RESONATE study. So there were quite significant differences actually in the patient population between the RESONATE study and the Murano study. That's important to bear in mind. Now, when you look at this fixed duration regimen, initially people were concerned that the moment you stop venetoclax, that then patients would relapse. But you can see here that the benefits of the fixed duration regimen are sustained very much beyond completion of therapy, with a median progression-free survival of over 50 months with the venetoclax rituximab. So this is very much trumping the 2 years of the chemoimmunotherapy treatment that I highlighted in the table at the beginning. Interestingly, there was also in this study an overall survival benefit, and this was because there was no crossover, number one, and number two, some of those patients, although only a minority, had also relapsed, on ibrutinib and before then, and so essentially, there were not that many options available for the patient treated with venetoclax. Most of them were treatment naive, with ibrutinib, and so they could switch to ibrutinib therapy. And I think that's clearly illustrating then that there's a survival advantage as well as the lack of crossover. We all know that venetoclax rituximab combinations are really well tolerated. There were no really major concern. The initial concern of an increased risk of second malignancy was not really confirmed with a longer follow-up, and numbers are very small. The same applies to Richter's transformation. So this is a regimen that is really well tolerated. Interestingly, of course, and importantly, with venetoclax containing regimen, as I'm sure you're aware, the rate of minimal residual disease eradication is very high in patients on venetoclax. And similar to chemotherapy, the MRD response is quantitative. So there are some patients who will get remain MRD positive, and then that translates into a poorer progression-free survival, whereas patients who in green here, MRD negative, have an excellent progression-free survival. So the same quantitative correlation between MRD and PFS is that we saw in the initial FCR studies is actually recapitulated in patients on venetoclax and rituximab. So that's, I think, is a really important finding, and we clearly have a very good surrogate marker of PFS with venetoclax therapy. The same cannot be said for the BTK inhibitors because, as you know, they do not induce MRD negativity. So overall, 60 of the 83 patients who were MRD negative at the end of treatment, and this is now more recent data, remain progression-free at 5 years, irrespective of the MRD status. So although the majority of patients, as you can see here, these are the 83 that are MRD negative at the end of treatment, of those, half of them became MRD positive, but actually only 19 of those eventually progressed to needing further treatment. So this is quite interesting, and essentially, I think it just illustrates that when you stop the treatment, in some patients, in about half patients, very slowly the disease will come back. What happens to the other half of patients, actually, we don't really know, and it might well be that these are part of the people who might be functionally cured. And again, we need longer follow-up, as CLL is an indolent disease, and that'd be very interesting to see this. Now, the exception to this seems to be patients with TP53 disruption. And you see here the curve, the PFS curve of those patients in the Murano study. In the purple line here, the patients who are wild type for TP53 disruption, and then in the interrupted line, these are the mutated patients. And you see that clearly the progression-free survival is not as good in those patients as it is for the wild type patients. And that's different from the BTK inhibitor studies. And, rather than thinking about a class effect here, I think we need to think about the fixed duration versus continuous therapy, but that is just me speculating. It's not really clear what's actually happening. When you look at the clonal dynamics of responders and non-responders following venetoclax retreatment, you see, in the incidence of the mutations, you see that there are actually quite some patients with mutations, TP53 mutations, who then do not respond anymore to venetoclax or obinutuzumab retreatment. That does not seem to be the case with ibrutinib as the next treatment. And is sort of, as clinicians, what we might expect. However, the time to next treatment in patients with or without TP53 disruption is not different. And also especially not in the patients who are MRD positive. So it's not really 100% well understood what's happening to those patients. My own view on this at the moment, with the current evidence, is that I would prefer to treat patients with TP53 disruption with a continuous regimen. So following on from these landmark studies, there have been additional studies, and I will go very briefly through them. There's the ASCEND study that compared acalabrutinib versus best clinician choice, either Idela plus rituximab or bendamustine plus rituximab, again in patients with relapsed refractory CLL. And unsurprisingly, the outcome data and the efficacy data is very similar to what one would expect with BTK inhibition. And you can see here really nicely the overlapping curves between the patients who are mutant and wild type for del17P, showing almost identical response with respect to PFS. With a median PFS that is still not reached in either of the groups. So then there's the Elevate RR study, again comparing acalabrutinib, this time with ibrutinib. And the reason why I wanted to briefly mention this study is because of the side effects, the very nice comparison that one can reach with respect to the side effects of the second generation BTK inhibitors compared to the first generation BTK inhibitors. And in this study, there were secondary endpoints and specific clinical endpoints that were collected with respect to these types of side effects, and I think it's a very nice study in that respect. So there was no real difference in PFS and overall survival between those two BTKIs, which is interesting in itself, but unsurprising. But then you can see that there was a clear a reduction in the incidence of atrial fibrillation and atrial flutter here in red in the acalabrutinib treated